Hello and welcome to TiCME, Time Critical Medical Education. Today's TiCME talk is about avoiding secondary brain injury. Brain injury is an incredibly important topic, and so what we're going to do today is go on a journey through how to manage the patient in the emergency department. So why is this such an important topic? Well, brain injury is not one of the conditions that we're going to provide in the emergency department the full care for. We're not doing the neurosurgery. We're not providing the months of rehabilitation. But we are intervening in the patient's journey at a critical juncture, commonly when the patient might be unstable or need to have an airway inserted. And in this situation, we are absolutely at the forefront of trying to provide excellent care and avoid complication. And to do that, to avoid secondary brain injury, it's all about the numbers. The first number we're going to talk about today is 8. Why 8? Well, it's the GCS, which is associated with worse mortality and worse return to independent function. For those of you who want a more complex scale, which has been validated at being better at assessing neurological function and prognosis, particularly in intubated patients, you might wish to have a look online at the full outline of unresponsiveness scale. 8 is also the number traditionally that means you must intubate the patient. Now, by no means is this a hard and fast rule, because you might have a CT scanner that's 200 meters away or a neurosurgeon that's 2 hours away and you might need to intubate the patient earlier or later. But an intubation is the opportunity in the emergency department to cause the most secondary brain injury if we get it wrong. And it's therefore the time where we have to be at the top of our game. So what is it that is so important to maintain during any intubation or procedure we do on the patient? Well, that's our cerebral perfusion pressure. And this number 50 is the bare minimum we need to keep, because below 50, the cerebral blood flow drops away precipitously. Above 150, it climbs massively. And in between, we have this amazing flat line, which is the cerebral autoregulation, which we know keeps our vascular caliber adjusted by the body to keep a constant cerebral blood flow despite changes in perfusion pressure. And you remember that cerebral perfusion pressure is our mean arterial pressure minus the intracranial pressure. So a massive change in either of those will cause significant change in cerebral perfusion pressure. The important thing about this graph is, one, it shifts to the right in chronic hypertension, which is very prevalent in Sri Lanka and India, and also that damaged brain that is ischemic loses its autoregulation. And so the response type becomes linear. A single change in perfusion pressure will adjust up or down the blood flow with no autoregulation. This is incredibly important to realize that in a brain injured patient, the more secondary damage they get, the less responsive they'll be to their intervention, and that will cause a vicious cycle of more damage. So what does that look like pathophysiologically? This graph on the right shows the different makeup of pathophysiological abnormalities that cause secondary damage in the main types of brain injury. On the left, we see a Venn diagram which shows how these insults cause a positive feedback loop. And the most important thing to note here is the hypoxia and ischemia diagram, which overlaps all three of these brain injury types. And hypoxia and ischemia is what we can cause in the emergency department, and that leads to secondary brain injury. So to avoid hypoxia and ischemia in our patients with brain injury, we need to make sure that the interventions we perform on these patients are as safe as possible. The key intervention is intubation. In my emergency department, I've introduced intubation action plans in the last 6 months to try and make this as safe as possible. The idea is to pivot the rapid sequence induction from being led by the intubator and therefore focusing on equipment checklists to being led by a team leader who looks at the patient as a whole, not just the anatomy of the airway, but all of the problems that could come out during the intubation, then make a plan to avoid those. Give the team a chance to prepare the patient and all the medications and equipment required, and then finally check that these preparations were put into place and available prior to starting. I encourage all of you to have a similar sort of plan for your intubations in the ED. Obviously, for a brain injury patient, we're going to have an anatomically difficult airway immediately because we have a suspected C-spine injury in all of them. And we also have physiological difficulty. And this depends not just on how the patient turns up, but what we're hoping to avoid. So even a person with a blood pressure of 150 might suddenly drop their blood pressure during induction. Even a person with a saturations of 96% might be hiding a pneumothorax, which could cause their saturations to suddenly drop. Now we're going to move on to the interventions that we can do in the emergency department to avoid secondary brain injury. I'm going to use the Brain Trauma Foundation's tier system as a framework for this. And as a backdrop, I'm going to use my favourite Sri Lankan animals. So of course, for tier 0, the apex animal in Sri Lanka, the bull elephant, who I encountered in Yala East National Park. So the first number for these interventions, number 30, is the simplest and probably most effective intervention you can do. And that's putting the head of the bed up to 30 to 45 degrees. So why does this help avoid secondary brain injury? Well, the three main reasons are: 1, it augments venous return to reduce intracranial pressure. 2, it reduces the risk of passive aspiration when lying flat. And thirdly, it increases pre-oxygenation of the patient significantly by adjusting VQ in the lungs. And this will avoid potential hypoxia during the intubation attempt. Finally, this might be the position that you end up with during a ramp situation for someone who has significant obesity. So, although this isn't possible in all departments, because your beds may not be adjustable, if you do have an adjustable bed, I feel this is absolutely mandatory. If there's a cervical spine injury, you're worried about a lumbar spine injury, you can tilt the entire bed, not just the head. So these next numbers relate to the oxygen molecule on the screen. 94 is the minimum saturations you should be willing to tolerate, and that equates to a PO2 of around 60. If your saturations drop less than 90% only once, that will double the mortality for a serious brain injury patient. So everything you do during intubation must be geared towards keeping this up, and that includes fantastic pre-oxygenation, including apneic oxygenation strategies, but also a very slick and well-rehearsed intubation attempt. The 300 relates to millimeters of mercury of oxygen, PO2, and that is because latest evidence suggests that hyperoxia can also cause secondary brain injury through free radical formation. So when your patient is safely intubated, make sure you dial back the FiO2 from 100 down to the minimum needed to keep the SATs 94 or above. So the next two numbers are 110 and 75. 110 is the systolic blood pressure that is absolutely minimum that you should maintain. 75 is the MAP if you have an arterial line, you're used to using that instead. This clearly relates to keeping the cerebral perfusion pressure above 50, and it's really important to realize that a single episode of hypotension increases your risk of mortality by 2.67. So that is one episode. How do you prevent that? Well, that might mean for someone who is very hypotensive already, maintaining the blood pressure with vasopressors, blood transfusions, etc. But for someone who's normotensive, it might mean preemptively giving a bolus of metaraminol just prior to the rapid sequence induction. When we think about our rapid sequence induction, it's really important to think about the drugs that we're going to use. My preference for an isolated brain injury is to use fentanyl at a dose of 2 to 5 micrograms per kilogram, and that normally means giving the person somewhere between 150 and 500 mics of fentanyl as a bolus. Now remember that a low GCS is already providing a significant amount of anesthesia to the brain, so we don't need to give a full induction dose for most people. Remember that ketamine through its ability to maintain hemodynamics, is cerebrally protective, it's not dangerous to give ketamine as an induction dose due to the risk of raising intracranial pressure. In fact, as you could see from the previous slide, it's far worse to cause hypotension than it is to give a drug which will maintain the blood pressure. So ketamine's my induction drug of choice for anyone who's got a borderline blood pressure or who's already hypotensive due to other factors such as blood loss from other trauma. The numbers 3 and 4 relate to the standard blade size for adults for a hyperangulated video blade and for a Macintosh blade. I think hyperangulated video blades have completely changed my practice, and I can't think of a better indication to use them than in a brain injury patient. Well, why is that? Well, someone held in manual inline stabilization cannot be hyperextended, so we'll have an anatomically more difficult view. The hyperangulated blade is far better than the Macintosh blade at looking around this corner. So you reduce the number of intubation attempts and reduce the chance of hypoxia. But also, not having to lift the patient's pharynx and compress the soft tissues with the Mac blade means that you're avoiding the sympathetic spike of Macintosh blade intubation, which avoids a spike in intracranial pressure. So for those reasons, I think a hyperangulated blade makes sense in a brain trauma patient. And finally, in our tier 0 interventions is the magic carbon dioxide number of 35 to 40, which is the millimeters of mercury of PaCO2 you need to maintain. Gone are the days where we'd routinely hyperventilate patients down under 35, but also we have to be vigilant to make sure we're not hypoventilating the patient because cerebral vasodilatation will result. So normocarbia is very important. If you're only using end-tidal CO2, which we routinely do, remember that it will be routinely 5 to 10 millimeters of mercury less than the arterial. So aim for 30 to 35. So next we move to the next level up of interventions for reducing intracranial pressure rise, and they are tier 1, represented here by the magnificent blue whale seen in the waters off Marissa on Sri Lanka's southwest coast. So these tier 1 interventions are what you might need in a situation where, despite everything you've done up until this point, you notice that the intracranial pressure is rising. That might be because the left pupil suddenly blows, or the patient gets suddenly bradycardic in a Cushing's reflex, or you do ocular ultrasound and see that the optic nerve is swollen on one side, not the other. In this situation, the number 3 means two things. Firstly, make sure that you've got appropriate heavy sedation for your patient. Their GCS is 3, and we don't want them fighting the ventilator, fighting the tube. Secondly, this represents 3% saline, which are our hyperosmotic agents. Now, in my experience, I much prefer to give 100 ml bolus of 3% saline to most patients than mannitol, particularly in those patients who are already hypotensive or borderline hypotensive. Although if you only have mannitol available, the weight of evidence suggests there is no significant mortality difference between mannitol and hypertonic saline. I think there is probably a difference though in patients who are hypotensive due to mannitol's risk at producing a significant osmotic diuresin. So everything that we are doing in the emergency department can sometimes not be enough. And we know that to reduce intracranial pressure and avoid secondary brain injury, that early evacuation of the large extradural hematoma or an insertion of an extraventricular drain is a priority. So the one here refers to everything that you can do as an emergency physician to advocate for your patient and accelerate this process of getting the patient to theatre. Sometimes that's about an efficient transfer to another hospital. Sometimes that's about advocating to the anaesthetist to make sure that your patient goes up next. But in any case, going to theatre as a priority 1 is incredibly important in brain injury patients. So what do we do if we're delayed to getting to theatre, or we're bed blocked to the ICU and the patient's intracranial pressure is not coming down? This is where we need to move to tier 2 interventions. And firstly, that is to sedate your patient heavily. In the old days of using thiopentone, that was a very effective drug. Propofol works, but it does cause hypotension. So this is a situation where you need to maintain the mean arterial pressure by starting an infusion of something like noradrenaline whilst you provide the amount of propofol required to sedate the patient heavily. Secondarily, you might need to increase the amount of osmotic treatment you're giving, and that would be, for example, in 3% saline, upgrading from 100 ml bolus to 250 ml bolus. So when the intracranial pressure is rising despite all the previous interventions, this is when we move to tier 3. These interventions are not quite as evidence-based as the previous tiers 1, 2 and 0. Firstly, a deep barbiturate coma, and this is ideally using thiopentone infusion and a EEG monitor, getting the patient to basically flat line. Next is hypothermia, which hasn't improved mortality in the studies, but does reduce intracranial pressure through reducing brain metabolism. Next, there's hyperventilation, which you might consider for a short-term benefit when you're transferring the patient to theatre, for example, and they've just blown a pupil. Prolonged hyperventilation does worsen cerebral ischemia, so you do not want to continue this indefinitely. And finally, decompressive craniectomy, which probably does have benefit when used very early in a patient with refractory raised ICP, and probably doesn't provide very much benefit, for example, on day 5 in intensive care. This is still controversial, and you need to include your neurosurgeons in this conversation. And finally, just a few more things just to cover very briefly. Seizure prophylaxis should be considered in patients with GCSs less than 10, penetrating brain injury, or extradural hematoma, or seizure in the first 24 hours. You should definitely reverse coagulopathy to reduce bleeding. You shouldn't give steroids, and hopefully no one does anymore. And finally, tranexamic acid. Look, I think the jury is definitely out on the role of tranexamic acid in primary brain injury. I'm not going to go into this today, apart from to say that I'm not convinced by a large amount of the literature. And if you don't have it available, I don't think that's a big deal. Okay, to finish up, I just want to summarize all of the numbers that we've discussed today. Firstly, 8. Remember that a GCS less than 8 means the patient's outcome is likely to be worse. It's not a hard and fast rule for a tube, but you really need to consider it, but also how to make your tube safe. 50 is the cerebral perfusion pressure, which must be maintained. Remember, that's MAP minus ICP. 30 stands for 30 degrees head up. All of your patients should be head up almost all the time. Laying them flat increases the ICP. 94 is the minimum SATs. Remember to avoid hypoxia. Go out of your way to pre-oxygenate the patient, but once they're intubated, wind back that oxygen until you have bare minimum FiO2. 110 is the systolic blood pressure, which you need to absolutely maintain, or a MAP of 75. 2 to 5 mics per kilogram is the dose of fentanyl for a stable induction, or ketamine if the patient's already hypotensive. 3 is the blade size for a hyperangulated video laryngoscope for a safe and gentle intubation to avoid ICP spikes and ensure first-time success. 35 to 40 is the millimeters of mercury for PaCO2. Remember not to hyperventilate or hypoventilate your patient. 3 stands for 3% saline boluses if the ICP is raised. And also for the GCS, you need to heavily sedate your patient to avoid ICP spikes. And finally, 1. Remember that in an emergency, we are just stabilizing these patients and need to prioritize them to the operating theatre or the ICU. Finally, thanks a million to all of you for listening in today and hopefully learning something, but also for the amazing selfless work that you've done during this incredibly challenging COVID-19 pandemic. In my clinical practice, I've been largely completely immune from the threat of COVID, but I know so many of you have been putting yourselves on the line day after day in really difficult circumstances. So thank you.